This is everybody. I'm hopeful this is going to be just an unbelievable night talking about two hip studies. We've got probably the largest group of individuals on with us talking about these two hip studies. So and really great people. So I'd like to start with the introduction. I'm obviously Rob Mansky, the host. My favorite and always great co-host, yes, Phil Page down at the bottom, or he's on the bottom of my screen. Phil, do you want to just tell who you are real quick?
Hey everybody, yeah, I'm Phil Page. I'm from Baton Rouge, Louisiana at Fran U DPT program, and I'm just honored to be here. Thanks to IJSPT and our sponsors, and this is cream of the crop of hip rehab, so I'm really excited for tonight.
Yeah, this is gonna be fun. Ashley is our Ashley Campbell, who already introduced herself as the IJSPT editors here, but can you tell everybody a little bit about yourself and
sure
about your hip knowledge and why you're on this panel with us tonight?
You asked me to do this. Yeah, so my clinical practice, I am the managing editor of IJSPT. Part of the reason if you ever email, you're getting emails at like the middle of the night hours or 4 a.m. is because I am in clinical practice full time as well. So I work at National Hip Institute at TOA here in Nashville, Tennessee with Dr. Thomas Bird, so hip arthroscopist. I've been primarily working with him in the hip and pelvis world for the last this is 9 years now. So quite a bit of experience with a variety of hip and pelvis issues, post-op, non-op. So looking forward, and all these people on here tonight have been influences in my life, mentors to me in this sort of stuff. So I think we should have some really good conversation.
Yeah, it's going to be great. How about Ashley D? Ashley, is it DeSantis? Is that correct? Ashley DeSantis. Can you just tell us a little bit about yourself real quick?
Yeah, so I'm from Pittsburgh, Pennsylvania, and I agree with Ashley. Like most of the people on this call have been my mentors over the years, so owe it kind of all to them. But I started seeing hips really when I was doing my orthopedic residency under Keelan at the University of Pittsburgh in one of our sports medicine centers. I helped start a hip preservation program more in the adult world at UPMC with a hip arthroscopist, Craig Morrow, out of Burke and Bradley Orthopedics in Pittsburgh. And recently I started about a year ago now. I got brought over to Children's Hospital to help start an adolescent and young adult hip preservation program. So now really my big focus is in the kind of open sphere with PAOs, surgical hip dislocations, and hip arthroscopy as well. So that's kind of my spiel there.
Excellent. Well, thank you for joining us tonight. We appreciate you taking the time. How about next, Keelan Inseki? Tell us a little bit about yourself, Keelan.
Hi, I'm Keelan Inseki. It's my small world. We're all a number of us in Pittsburgh here tonight, and I work at the University of Pittsburgh Medical Center for Sports Medicine, kind of a couple of different roles. I'm still in clinical practice, up to 20 hours a week, seeing primarily hip pain of all kinds of hip patients, all ages and types. Some residency administration and some roles in clinical innovation. And I got my start in the hip world. Kind of Rob and I both were same time. We're much older than Ashley is. So around 2001, I think, when Mark Philippon had started at the University of Pittsburgh Medical Center, and that's when we kind of got involved and kind of lived in that role to some degree ever since.
So I didn't even pay attention. We have two Ashleys and we have two Robs on tonight. So Rob Roy Martin, tell us about yourself, buddy.
Yeah, so I'm also at Pittsburgh. I'm at Duquesne University. Like Keelan, I've started with Dr. Philippon in the early 2000s when he was at the University of Pittsburgh, and got to be at point of my ISHA sign here. So I've been involved in ISHA since its inception. So I've had the honor of working with some of the most outstanding surgeons in the entire world. So I still have the clinical practice, but also involved in really hip preservation research of all kinds. So
great. Thanks, Rob Boy. Mike, do you want to introduce yourself, or are you just going to stay behind the scenes?
I'll just stay behind the scenes, watch you clowns.
Okay. All right. Feel free to jump in if you want to, though. Okay. All right. So our first study tonight, everybody, our first study that we're going to talk about is by Michael J. O'Brien and a whole host of authors who I'm pretty sure I would butcher their names. So I'm just going to stay with Michael O'Brien because I know I can pronounce that one. But the article is out of IJSPT, Physical Impairments in Adults with Developmental Dysplasia of the Hip Undergoing periacetabular osteotomy, a systematic review and meta-analysis. Okay, so that's our first article. We're going to go over this for probably about 20 minutes or so before we move on to the second article of Ashley Keelan and Rob Royce. So first of all, I guess I'll start with a couple of questions, and they're really open to anybody. First one I wanted to ask really to Phil, though, because Phil's kind of on our panel here. Really, well, he's here for multiple reasons, but one of his, I think, his greatest assets to us here is talking about the research design and the research study and the methods and things like that. So I wanted to start with him. I really didn't really fully understand this method. They used what they called a methodological quality score. And they had a score that really ranged in the studies that they reviewed. The scores ranged anywhere from 39 to 88, which seemed like a large range to me. And so I guess my question is, can you explain to us, Phil, what the methodological quality score is, how they use it, and is having a range that large really beneficial for a review like this? I mean, what does it tell us?
Yeah, so when we do these meta-analyses, we want to have what we call a grade of evidence, which would be kind of what's the quality of the evidence and the quantity of the evidence. So you might have that, you might see these grades of A, B, C, D, that kind of stuff. And it's really related to the quality of the study. Now, quality, this is where in research it gets a little dicey, because that term tends to be kind of bastardized, if you will. There's, to me, two components of quality. One is reporting and the other is bias. And so there's different, what we call these checklists or reporting guidelines that are specific to certain designs, right? So every design has certain qualities that you want to meet. And so if you go to, there's a great website called equator-network.org, which lists all of the different reporting guidelines for different types of studies. On the other side of that are the risk of bias tools. The most common you're going to see, which we're probably familiar with, are the Pedro or the Cochrane risk of bias. This study, and let me just back up, those for the risk of bias, right, they tend to use randomized controlled trials. The thing with this systematic review is that they included cohort studies, and that requires a different type of analysis of the quality and the reporting. So they use the Downs and Black scale, which is pretty good for including these non-randomized trials. And of course, in this type of cohort or this type of study, typically in surgical interventions, we don't always have these randomized controlled trials. And of course, we all know as clinicians that RCTs have their limitations. So large cohort studies, they're fair game, in my opinion. So what they do is they score and give you some kind of limit or some number of the quality. And I use air quotes because that number is quite arbitrary. Here's what I found. Okay, this was interesting. First of all, when you pull up, you have to pull up the actual appendix. It lists all of the studies and the grades of quality from Downs and Black. Here's the thing, Rob. Only one was 38.9. The rest of them were 62.5 to 87.5. So there really wasn't a big range. It was that
more of them were higher than lower. Yeah.
Yeah.
Okay.
Here's where it gets interesting. They claimed that a 60% score on this Downs and Black was a good quality study. So this is where I want to give a little education of people about reading the literature. Don't take what the writers say at face value, right? I teach my students all the time, you need to be a critical appraiser. It's like a marketing thing from a product. Don't believe everything you hear, even in a journal article that's written by professionals, whatever. So I go back in here and I look and I say, where did they get this 60% from? Where's the citation? It goes to another study. That study then cites another study. And that study cites another study that didn't even use down in blacks.
But they
These
use
are totally
60%.
totally different scale.
Cool. Yeah.
Called the epidemiology appraisal instrument. it's like a comedy here to see how they actually came up with this
That's
60%
yeah,
score.
percent.
Regardless. So as I said, they're arbitrary. What that means is they're open to interpretation by the reader. And I would tell you that their other issue is they use a modified version of the original Down in Black, which is kind of an issue. But they tried to cite other HIP studies that had used it. I would probably venture to say these were pretty good quality studies overall, given the design. See, let me finish with this point. Downs in Black would give you a higher level of evidence or a higher grade of quality in a randomized controlled trial. So in order to get that higher score of the original Down in Black, you had to have a randomized controlled trial. What they did with a modified version is they took that out of the equation. So now they brought it from 27 items to 18 because the rest of them had to do a randomized controlled trials. So
it totally changes. Yeah.
It's not exactly a good study because 10 of them were cohort studies.
Yeah. That was another question I had for you. That had 10 cohort study, 3 case control, 8 case series, 2 cross-sectional studies, 1 feasibility study.
No randomized controlled trials, was there?
Yeah. Well, I don't not know.
I can keep going, or we can come back to that question.
Yeah. Let's move on. Let's move on. I think you made your point. Or I feel like you have. Ashley C. This article says that so looking at outcomes after PAO surgery, most of them, I think prior to now, were based on imaging, it sounds like. Is that changing? Shouldn't we have more objective ways of looking at outcomes other than imaging? Because we all know how imaging, you can see horrible arthritis and the person has no pain whatsoever, and then the next patient has hardly any arthritis but they're having horrible pain. Imaging can't be like the best way to look at outcomes, and is that changing now in the hip?
Yeah, and these patients and certainly the others on here have substantially higher numbers and experience with the PAO patients than I do, because Dr. Bird doesn't do PAOs, but some other surgeons I've worked with do. These are typically they're younger patient population. The oldest person I've ever seen with a PAO was in their like 38. So obviously from an imaging perspective, success to the surgeon is a healed, fused, reconstruction of the pelvis basically. But these tend to be very active, high level individuals. They're typically, not to stereotype, but they're usually athletes. A lot of them, if they're females, are dancers, gymnasts, those sorts of things. If they're males, they tend to be, I see a lot of catchers, hockey players, things of those nature. So their outcomes from a patient specific goal, certainly great. My pelvis is healed, my bone is healed, but from a outcomes perspective, I think, some of our proms are certainly appropriate. Strength and return to function, return to their sport should be being tracked. I think that's where our group, from the Isha perspective and those sorts of things, that's what we're looking for as non-surgeons from the PT perspective.
Yeah. Keelan, Rob Roy, you got anything else to add to that? Or
and Rob and Ashley may have looked at this more recently. I mean, the last time I looked at PROMs in this group, they were validating the WOMAC, the HOS, not the HOS, the WOMAC, and brought the other one in 2019, and they said it had appropriate psychometric properties. But I don't know, you guys would know better than me, so I'll jump off there, Rob or Ashley. Have you guys looked into this further with the HOS, HAGOS, IHOT?
Yeah, I think most for the promises, the promise has promise. That's bad, right?
I got it though. No one else laughed, but I understood it.
And then the IHOT has, the IHOT 12 is also something that has some evidence to support it. So, I think some of the way they pooled this in the abstract kind of gives artificial that, there are a lot of, they have a big pile of subjects and it could collect it all, all the information to come to these summaries, but really you only had 1 or 2 studies in some of the related topics that they, kind of pushed together to summarize. So there's really not 2,000 subjects that came to all those conclusions. And then, as we all know, physical impairments aren't always the best indicator of outcome, because we've all seen patients who are, weak or stiff, or, kind of, we don't really know what some of those mild gait abnormalities that they continue to present with, how does that really impact their overall quality of life? I mean, some of these folks are pretty debilitated when they come in. So, may have made a huge increase, in their overall quality of life, which some of these physical impairment measures might not get it. Yeah.
Yeah. We use I think it's thinking about the imaging part of it. We actually, with the surgeon that I work with, he takes images at 2 weeks, 6 weeks, 3 months. If they're healed, he doesn't take another image really for quite some time. And so, once they're healed, he focuses less on what's happening with that osteotomy on imaging and more based on the promise, the IHOT. And then we have started, looking at certain milestones, functional testing, and, at, 3-4 months, what are they doing on single leg squat or single leg stance or something like that. And then looking at higher level of function, later down the road. But the imaging thing is, for us, it's just the measure of, can they progress off of crutches? And then from there, our outcomes really look more at, some of the proms and their function. So.
Great.
And there's one other thing, Ashley D, you can probably chime in, but I think a lot of the surgical techniques have vastly improved over the years. If I'm not mistaken, I think Dr. Ellis in Columbus is doing some novel things, much less invasive. And, we've showed now that the outcomes of PAO are just as good as hip arthroscopy at 6 months and 1 year and 2 years, which is, honestly kind of surprising when you think of all the surgery that these people undergo, all the trauma.
Yeah, I think rehabbing a PAO sometimes is easier than a hip scope. I mean, I think people get so obsessed with the fact that their incisions are small that, but they went in that joint capsule, right? And if you have an isolated PAO, it's really bony healing. And if you've got a good surgeon who gets good coverage and that osteotomy heals, it can be a pretty easy slam dunk really to kind of rehab these people, because their muscles really just kind of, come back. But yeah, that's always a hard conversation to have with people, though. They've got this big incision versus these small, if they've had a scope in the past, these kind of smaller incisions, that kind of mind game with patients can be hard, I think.
Great. So in this systematic review, they talked about how hip pain, the change of hip pain was questionable, although just overall iliopsoas and abductor pain was decreased after the surgery. What all causes that change to occur, to cause everything to decrease? Is it just the realignment of everything, or what all goes on there to make that change?
We probably all have opinions on this. They're probably all similar.
Yeah, I was going to say, I think we're probably agree on.
Yeah, I think from what I see is that, when you have someone who's undercovered significantly, obviously you lose that. We talk about the layer concept of the hip. You lose that bony integrity piece of the stability of the hip, and therefore your dynamic stabilizers have to work way over time. So most of these people have a lot of irritability of iliopsoas and the abductors. They're overworked and underpaid, basically. So I think just lessening the demand on the musculature significantly helps the pain associated with soft tissues, and from what I've personally experienced.
The others, would you all agree?
Yeah, I think exactly what Ashley said, and then they get a little rest because they're not doing as much after the actual procedure, so they get some rest time. When they do start becoming active again, they have better coverage, or they should, and it sets them up for less of that extra-articular discomfort, or the sources of extra-articular discomfort.
So the other thing that they mentioned was that after this, even though their iliopsoas and abductor pain decreased, at least if I understood it right, when they looked at strength, the strength changes were really minimal. So their overall hip strength didn't change drastically. So how is that? Is it just the more coverage and the better alignment of everything? Then the hip musculature can calm down because it's not having to work as hard, and because it doesn't have to work as hard, maybe it doesn't need to get stronger. Or how does that? You would think that they would probably get stronger too, or I guess I would think they would maybe get stronger too. But this study said strength really didn't change, or the strength changes were relatively minimal.
There's some other studies that look at strength that show that there actually are some good changes pre and post-op in those muscles.
Okay.
I think the one thing to remember, there's one study that compares them to healthy, and while they do improve pre to post-op, they don't actually show that at 1 year they get back to similar to what a healthy person would be at, like, you know, just in their abductors and flexors. And so I think it's the coverage, right? And it's the ability to kind of activate those muscles. But I think Keelan made a good point that rest, you can then start patients at their baseline strength, right? So then you can make sure that they're getting good activation before you progress them into the more functional phase. And I think kind of taking them all the way back to that step one is incredibly helpful, because it kind of teaches them how to use their muscles, whereas they've been using them probably completely wrong before. But there is that one study, but it doesn't get back to healthy. But I think that's probably because these patients have been in a deficit for many years now, right? This wasn't something that just happened overnight. So
yeah, it's pretty chronic. Usually these are chronic issues, and yeah.
And the other thing would be PT. I mean, we don't really know what kind of PT these folks had. So that could be all over the board. And I think that, you know, over the years, we've gotten much better at rehabbing these folks and all the, you know, just kind of getting these folks better. So we don't really know the rehab, which obviously can play a humongous role in the outcome. So.
And I would think Ashley could probably speak to this. And Dave Korheiser out in Columbus has said this, that I think a lot of these people are underdosed in PT to actually make strength gains.
Yeah.
It'd be an interesting study to see how you did it if you actually made it to a true strength gain being dosed appropriately and treated that way, if you'd have additional benefits. But I think a lot of people, it's probably getting better, but not familiar with the surgery. They hear about the surgery and what it entails. And I think they are too cautious at some point and don't dose them appropriately.
I think
or
that's
you
a
look
lot
at
of
the X-ray and you're like, holy smokes, they've got
Yeah.
3 to 5 screws in there. And I think Keelan, you're totally right. Like, we have patients who come who are rehabbing, you know, an hour or two away from Pittsburgh. They've only seen one PAO and they're at 4 months and they're like still on the table. Right. So like, I think that PTs get scared because it does look like a huge procedure, and it is a big procedure, but you know, it's more of a fear thing to progress these people than
There's a lot of surgeon specificity to that too. So if we look at all these papers and who was behind the scenes of the actual surgical procedure, there's differences internationally as far as just how they handle physical therapy in general. And so, yeah, I think we're not really, I don't know that we're comparing apples to apples when we're looking at this.
Yeah, and I don't think this is isolated to just hip surgeries. I mean, I think we're underloading a lot of different people post-surgically, more than we probably realize. Do they didn't really talk about this a lot, but typically before surgery, do the patients usually, don't they normally have some conservative care prior to? I mean, they have therapy right prior to, but it just doesn't seem to be working. And that could be could that be the overloading issue too? Or do you think it's just there's so much symptoms that the conservative therapy in a lot of these people isn't working?
I think it depends on the surgeon as well, what their kind of pre-op path looks like. I know for us, it's pretty standard unless you're severely undercovered. You go through, 6 weeks of good conservative care with a hip therapist. And then it's only then do you get joint injection, CT scan, surgical planning. So there's like a good 6-week period. If they're severe, right, then that's a different story. But if they fall into that more borderline case, then we definitely have a good 6 weeks of good conservative care before they even start down the pathway of imaging for surgical planning.
Yeah, that's what I assume probably happened. I guess I have just one more question. This really didn't seem out of the realm of possibility to me, that they looked at people or patients that had poorer running and functional task. The people that were symptomatic PAO patients typically didn't do as well as the people that were asymptomatic. And that just seemed kind of like a given to me. I mean, if they're not having as much symptoms, wouldn't you assume that they're not going to have as many problems? Or doesn't that seem normal? Or I mean, I'm not sure why that was reported. You know what I mean?
Yeah, I think the only instances where I've been just kind of, I shouldn't say only, but the instances where I'm usually pretty impressed with the how well people are just kind of getting by is like these from the professional dance. Like most of the people I've seen is like the professional dance realm where you're just like, you've done what with this hip? Like it's pretty impressive. But yeah, I mean, I think it's fairly common sense if you're significantly undercovered and you're trying to push through at a really high level, certainly with things like running and that sort of stuff.
And you're symptomatic.
Yeah, yeah, you have pain. You're most times pain influences ability. So
yeah, we have a someone posted here. Jacqueline made a comment. The issue is it is also not taught, especially in PT programs. I'm a second-year PT student, and it's not a huge topic, but adult dysplasia is so prevalent now. I believe it should be talked about more. When I talked about my PAO in my class, or even to PTs, no one ever even knew what it was. So
yeah, I think it's, well, I can only speak to our program. Obviously, we talk about it in our program, but I definitely think, I mean, I speak a lot. Everyone on this call speaks a lot all over the place. And I teach other classes that are non-hip related. And the number of times I'll be speaking in a class and I say the word PAO and I just get glazed looks, or I talk about hip dysplasia. It definitely is, I think, no pun, but an undercovered topic.
That was on Rob's level.
Yeah. So yeah, I would agree. I think, it's not that adult dysplasia is more common now. It's just, I think we do a better job of identifying it. We have better skills and techniques to address it. And, the whole idea of hip preservation is not just hip arthroscopy. PAO is a hip preserving technique, and older people are now qualifying for that procedure.
Right.
Yeah, and to be honest with you, in a PT program, I mean, how many, if you have 50 kids in your class, how many people are going to be specialized into a
Right.
practice that does that? So it's kind of, while I can appreciate Jacqueline's comment, it's just hard to cover absolutely every little nugget. So
Sure.
people who are certainly interested, we all have papers and topics, and that's why we do this, is to, if you have an interest in something, to learn a little bit about more, and hopefully the foundation you learn about anatomy and biomechanics can carry you to that level.
Yeah, great points. Great points. Does anyone else have any other questions about this study they want to bring up before we move to the second?
Yeah, let me close this one out for you.
Okay.
This is not a systematic review or meta-analysis. It's in the title, but it's a very poor example of one. And I think what the authors did is they tried to set out as a meta-analysis. We all know that meta-analyses are the top of the food chain, and it gives you a bunch of credibility. But in reality, they had, again, the only real meta-analysis they did was on 2 studies at one time point. And they tried to, in these figures, create these forest plots where you'll see in figure 2 and 3, they compared only 2 studies the first time, and the next points are from 1 study. I think this is a poor example of what a meta-analysis would be. And if I ran an AmStar analysis, which is a appraisal of systematic reviews and meta-analyses, this would score relatively poorly. And this is where we started at the very beginning. This is more of a scoping review. And it's okay to be a scoping review. What they did was they pushed the limits on this one. And in my opinion, I don't have validation of this. A meta-analysis needs to be done on comparison of 2 groups with, like a standardized mean difference. They did their best for a best evidence synthesis. But then the next set of things were based on observational of the presence of these anterior impingement symptoms. To me, that's not a meta-analysis. So back to Rob Roy's point, when you read the abstract and you see 2,000 patients, no, do not stop at the title. Don't stop at the abstract. Become a critical appraiser of the evidence, and don't believe everything that you read from a title and abstract. Go in there, dig into it. Problem is time and knowledge. but that's why we do these. So I appreciate that, Rob.
Yeah,
Thank you.
no, thanks for bringing it up. You know, I just, and another journal that I'm a reviewer for just the other day, I said that I think we need to reject this because it was a similar situation where it was a systematic review meta-analysis, but there were several of the outcomes they looked at only had, I mean, they had, I think, a total of 10 studies, but some of the outcomes they looked at, they just compared 2 studies. I mean, there were maybe 2 studies. And so it's really hard.
And it just gives meta-analyses a bad name. It gives,
Yeah.
now Malachi McHugh more fuel for the fire
Yeah,
against
exactly.
meta-analyses.
Yeah,
All
I
right.
think we just had that commentary in JSPT in the last few years about looking at surgery versus non-surgical treatment for FAI, and they were all over the weaknesses of those meta-analyses, which were actually probably better done than this. So and for having less than 5 studies. So yeah, what Phil put it more eloquently, but it makes sense.
Yeah, yeah.
Yeah, just one more thing about the outcomes of PAOs. I mean, for those who might not be that familiar with it, they often have hip arthroscopy combined with PAO simultaneously. That's really the new thing. So, I would just read this study with caution and recognize that certainly things have changed. And when they used to do just PAOs, I think they found out those don't do as well as when you combined your hip arthroscopy taking care of your labrum in addition to the osteotomy. So I think, we're finding that the outcomes are very good, at 2 years even. So just a kind of a little information about when you're looking at PAO literature, you want to know, did they just do the PAO, which has poor outcomes when you do PAO with a scope?
Okay. Any other final thoughts on this one? Or are you ready to move on, guys? Move on. Okay. Ashley D, could you just tell us a quick, give us just a very short overview of your paper?
Yeah, so our kind of goal in our HIP program is there's so much low-hanging fruit in the dysplasia world in terms of what can be done. And there's nothing really out there in terms of rehab guidelines, as we just talked about. Like there's barely any studies looking at strength pre and post-op. So we wanted to get together a group of experts and we focused on North America. And we wanted to create an expert-driven kind of guideline for postoperative care of these patients. And I think Rob just brought up a great point. We focused on isolated PAOs. This is, if people have concomitant procedures, generally a hip arthroscopy doesn't change the outlook, at least in our center. If someone has hip arthroscopy, this is a very similar progression to what we would use. There's nothing really that would be done differently here. But there are some other things, like if someone has an open surgical hip dislocation at the same time, or maybe some type of, Oates procedure to the femoral head, something like that, then that's a little bit different. But if someone has a PAO and a scope, I think this is pretty on par for that as well. So we kind of pulled the group. We came up with the questions and we focused on immediate precautions, strength phase, and then return to sport were kind of like our 3 themes. We had a series of questions and we did a Delphi and came up with a consensus, for the 11 questions. And that consensus is what we presented in this article.
Fantastic. Phil, do you mind just for people, some of the listeners that maybe don't really know what a Delphi study or the Delphi process is, do you mind explaining that briefly just to get everyone up to speed before we start digging into it?
I love Delphi studies to begin with, and they aren't well known in how they're done. But, as Ashley was saying, you get an expert group and you ask questions and get feedback, and you go through these different rounds of questions that are refined as you go through this. You develop these themes, as she had mentioned, that come from it. And then you try to develop this quote unquote consensus. And so I call it kind of like a survey on steroids. And it's also like a qualitative study where it's a lot of just opinions and things. These are really more refined opinions. And, you had, what did you have, 16, I think, and probably half of those people are on this call. But so the question that we were talking about beforehand, Rob, was how many do you need in a Delphi study?
Yeah, that was another one of my
Right.
questions.
So we know that power, statistical power, in order to reject the null hypothesis and all that has specific formulas. Here's the thing, in Delphi, they don't have that. Delphi's really, we don't know. So you always default to 30. That's like, seems to be the number, which is the regression to the mean number is, so let's just go with 30. But here's the thing with the number of individuals for a Delphi. It depends on the question. It depends on the individuals, the quality. And based on what Ashley and you guys did, you were looking at the experts in hip rehab in North America. I think there's 16 of you. So I don't think you missed anybody. You know, now in terms of, and you talked about it in the paper, the generalization to the rest of the world, you can't make that. I really like this study, not just because I'm not saying that because you're on right now, because, you know, Rob, I would tell you if.
Oh yeah, Phil
we
will
were on
rip
the
people
paper,
if they're yeah, even if they're on. It happens.
But I thought this was really well done, and it went through 3 rounds where you developed the you know, open-ended questions, refine the questions, go back to the panel 3 times to get a consensus, and then you have this beautiful, very clinically applicable document at the end. I just loved how you guys went point by point, and you have pictures, because I like pictures.
Yep.
Comic book stuff. That's about my level of education. You guys made this so clinically relevant with the actual experts. I thought it was a great study for the topic. So my wrapping up, what I would like to say is when you look at a Delphi study, to get back to what you're talking about, Rob, it really is about the reader and understanding what is going on with that question, to know that this is a true representation of what the experts believe in this topic in North America.
Yeah. One of my other questions was in regards to the at kind of each level, there seemed to be a lot of agreement, but that now makes sense after what you just said, Phil. Maybe because I was thinking maybe just everyone agreed with each other. Maybe that isn't good, right? Because everyone agreed with each other. But
Yeah.
Now, after hearing what you said, if you've got the experts and they're all agreeing with each other, and you only have, and my other question was about numbers, so you have lower numbers, but if you have all the experts and they all agree on it, then it's probably right. I mean, it's probably a good thing, not necessarily a negative thing.
That's exactly right. So if you wanted more numbers, you would get people that aren't experts necessarily, right?
So then you might get more disagreement, but you don't want, you don't want that.
So it's all in the context of the question, the situation. And I think this is, you know, I mean, the hip is a very niche a thing to treat. And literally, this is the group right here on this call tonight in North America that knows hip rehab better than anybody in North America.
Yep. Great. Let's go with Keelan. Keelan, so I just have a lot of questions. Again, I think because these may seem like very basic questions to all of you guys, but I think just as what we're saying, a lot of the listeners don't really understand the injury and the procedure and the rehab, they're probably not going to understand all the details exactly of, you know, why you guys decided at these ranges and when to do this and when to do that. So one of my first questions is, can you explain the range of motion limitations? Why flexion to 90 and ER only to 20 early on? Why, what goes bad?
Yeah, you know, admittedly, some of those range of motion, and I'll let Ashley chime in on this. Well, she's seen more than I am these days. Both Ashleys, probably. But you know, that's one of those things that some of it's a bit arbitrary, I think, right? And it was probably born out of conservative measures to protect the bony healing that occurs with the process. And also, I think, to be honest, I think to also protect soft tissue, and not so much protect as you're going to damage soft tissue, but not to set off this cascade of irritability, which then just becomes a bear to deal with. And then during that early time period, you're waiting for the bone to heal anyway. So, and that's, you know, that's not the most comfortable, you know, time period. But now it seems like it's much better in terms of pain control. But you know, to force the range of motion at an early time for the sake of just getting it, when we don't tend to, these hips don't tend to be very stiff. These people probably came in somewhat hypermobile anyway.
That's what I was wondering too. Yeah.
But you know, when you get to these very specific measurements, because it happened with hip arthroscopy too, and then it did evolve over time. Some of those like exact 90 degrees for external rotation, or excuse me, flexion, external rotation, and limited external rotation seem to be the same across protocols. You could probably guess that some of those were just carried over. Someone in fellowship, a surgeon in fellowship, took the protocol that existed previously, carried it over. And it also wouldn't surprise me, and I'll let the others speak on this because they probably would have even a better idea, that those might change over time. This Delphi study does that for you. It kind of tells you what people are doing, and then that can be challenged with variations in the protocol, and you have something to compare against. This is what I do. This is what everyone else has been doing as a standard right now. So I wouldn't doubt to see that there's range of motion or other, the other issues. Probably weight bearing's a little trickier because you know what you're dealing with there pretty well. Yeah. But I wouldn't doubt to see that some of those things change over time.
What do you think, Ashley or Rob? Anything to add?
I think that I agree with Keelan. I think part of it's been carried over from the scope kind of population, but I think the hypermobility part is very true. These patients are not stiff, so there's absolutely no need to be pushing
get it anyway.
Motion. They will get their range of motion back. So I think one thing you can do very wrong in this patient is push their range of motion. If they're uncomfortable into range of motion, if they're having pain with any range of motion, just don't do it, right? I would rather not do the range of motion. I know they're going to get it back, than kind of try to get them to 90 or 100 or whatever, and them having some groin pinching or whatever, whatever it may be. And that goes for rotation too. I think some, 90-degree gentle circumduction, these patients, they never feel, in my experience, they really never feel stiff. So just don't push into motion. Let it be gentle, let it be progressive. They will get there. And it doesn't need to be in the first 8 weeks. It's not like an ACL where if you don't get knee extension back or knee flexion back on the early end, that you're going to hinder quad. It's not like that. So just don't push into pain with these patients and just let it come back naturally. It will come back. I don't know that I've ever, and you guys can comment as well. I really don't know that I've ever gotten a stiff PAO, but that could just be me. So,
any of you? Did you ever have any that are stiff?
No,
but I've seen some that one or two that came in. It wasn't my fault. I didn't see them here. From out of town that had HTOs and such, from aggressive range of motion, which is the worst thing. Well, it's one of the worst things that could happen because you don't have a lot of options when that happens. So,
yeah, they're not stiff by our standards. Only, again, dance population, gymnast population, they're stiff by their standards in their brain. But it's not a stiffness issue.
They can be really loose, but they feel stiff. Yeah.
I think that's a really good education point, because one thing we really hammer with our patients is your socket is different now. So your coverage is different and your range of motion is supposed to be different, right? You had non-physiologic motion before you had your procedure that was causing this cascade of problems. So if you look on the back end, your hip will feel different because you have different motion because you're now covered. And so oftentimes that difference in range of motion is exactly what we're looking for in terms of saying, well, you're covered now. So your hip is doing what it's supposed to. And that may feel different, but that's actually a really good thing for your long-term hip health.
Yeah.
It should feel different. And if your other side is dysplastic and you need a PAO on the other side, your two hips are going to be different until you get to that other side on the PAO. So, or they could be asymptomatic on the other side and, at least in our center, we're not really going to touch someone who's asymptomatic if they have mild dysplasia. So their hip should feel different. And I think that's a really good education point for these patients.
Yeah. And it's a really important preoperative education point.
Yeah.
When that the expectation is set that, this will be different after surgery because we want it to be different. So.
All right. So any one of you, tell me why there's always a talk of hip flexor protection, and it's with this paper for this procedure. It's also with FAI procedures, things like that. Why does the hip flexor get so irritated?
I think in this population, their hip flexor is irritated pre-op because it's overworked. And so it's a hypertonic problem pre-op. I think post-op, there's a cut for the osteotomy that runs right underneath the hip flexor. And so as these patients are healing that osteotomy, that hip flexor can get very easily inflamed. That's one of the biggest reasons why we protect it, is there's a piece of the osteotomy that's right behind the hip flexor. And so we just don't want to irritate it. And we all know that coming back from an irritated hip flexor is the worst.
Yeah,
So
yeah. In the, I think it talked about like how often, a little bit about how often you see the patient. So the first 6 weeks, are you guys seeing them really often, or because you can't really do much early on, or do you see them a lot, or do you really wait and kind of hold your, is it minimal like hands-on therapy with a therapist at that time frame, and then you see them a little bit later when you can actually do more things, or do you see them a lot early too? How does that work in your instances?
And I bet that varies and probably depending on who you work with. Often it's just a practical scenario. This is going to be a long rehab. So, I can give you an example. We have I work for UPMC. We have a health thing. If you 25 visits per year, you get the surgery in January and you're going to be rehabbing a long period of time. You have pretty high functional goals. This first 6 weeks, we don't want to excessively utilize those visits. So it's a planning issue. And that's where you'd probably see a big variation in other countries, or professional athlete has unlimited resources. They'll probably be in there all the time. But, for us, I look at it's protection phase. The bone needs to heal. Sure, if they could come in more often, but is it going to make a big clinical difference? And I know Ashley's kind of leading up one of the utilization review we're looking at right now. It probably doesn't, but so for the people for resource management, to me, if it's going well, I don't bring them in very often. I don't know what everyone else would say on the panel.
How about you, Rob and Ashley?
Yeah, I mean, I agree. I mean, sometimes less is better. And I think that's sometimes why this group does a little bit better, is because they're not always pushing the envelope. You're just let you get the bony soft tissue healing. And once that takes, then you can hit a little bit harder. I often find that, and I'm probably guilty as this as anybody, when someone comes in, you feel you need to do something and the patient. So you have a tendency to do more, which I think, as we find a lot of times can be counterproductive, because you end up irritating, particularly soft tissue. And if you're not really smart, in untrained hands or people who don't have any experience, you could, kind of slow down the bony healing. So, probably once a week would probably be more than enough, depending on your patient's compliance questions and how they're doing. So just kind of milestones to make, milestone checkpoints to make sure they're moving forward.
Meeting what they need to at that time frame.
Mm-hmm.
Good. So on your weight bearing, so after the 6 weeks, so they're typically non-weight bearing for 6 weeks, then weight bearing is tolerated afterwards. Is it just as tolerated? I mean, they can literally do 6 weeks in one day. They can do as much weight as they can put on it, or do you grade it over like the next several weeks? How do you guys handle that?
We personally grade it over 1 to 2 weeks. So if they come in at their 6 week mark and he's happy with osteotomy healing, then we grade it over the next 1 to 2 weeks. Okay. And it's generally flat foot. So we never keep our patients fully non-weight bearing. We keep them in a flat foot, 20% weight bearing position for the first 6 weeks, just to not aggravate the hip flexor. So flat foot on the ground. And then once you hit that 6 to 8 weeks, you've got good bony healing, then we take, as tolerated, the next 1 to 2 weeks to come off of crutches. And in my experience, most people, really cruise through that next 1 to 2 weeks. So.
Is you guys, Keelan, Ashley, and Rob Roy, do you progress the same way? Do you progress differently than them?
I've seen it from the same surgeon a good bit of the time.
So yours the same?
A couple, but I don't know what Ashley says, but and Rob and I would be in the same situation because we're actually same clinic. So, but that
I'm probably the only one seeing him from someone else.
Yeah, we have one surgeon in Pittsburgh who does it. So
and ours, it's interesting because it evolved with time. She came from somewhere else, and then working with us from the therapy perspective and just educating each other, we over time, like when she first showed up, a lot of times she kept her PAOs toe touch to some extent or foot flat for closer to like the 10 weeks mark. And we got her to drop down closer to 6 to 8 weeks, just depending on bony healing. So she'll do her x-rays typically at the 6 to 8 week mark, just depending on where they're coming from. And once cleared, then we progress them as tolerated. So we've kind of accelerated the rehab for that particular surgeon as well.
I was, I have to be honest, I didn't know this, that you guys talked about this Philippon study that showed high hip flexor EMG activity with the clam and doing hip abduction. And I wasn't aware of that study, and didn't know that you had that high hip flexor activity with those activities. Are there any other exercises that I think we would typically not connotate as having high hip flexor activity that do, other than clam and abduction? I mean, I guess I would think clam and abduction had hip abductor high activity, maybe some extensor activity, rotator activity with the clam, but I didn't think at all that it would be really have high hip flexor activity. Are there any other studies that you guys know of, or any other exercise you know of that have been studied that show, that aren't typically ones that you think would have high EMG activity to the hip flexor that actually do?
I
This
think
is isolated study. Yeah.
Yeah, I'm terrible at citing particular studies with like dates or anything. I think there was one that showed some, depending on with like banded sidestepping, depending on the placement of the band and the position of the feet, that it varied in what the hip flexor activity was. But it's interesting. I think the probably the number one exercise as like a hip specialist that I get asked about is the clamshell, and the poor clamshell has gotten just beat down. I mean, it is like the evil stepchild of all things related to hip. And I honestly think it's a hard, that and correct sideline hip abduction are very challenging exercises to do correctly when you have had a history of hip pain. I think there's a lot of overcompensation of the hip flexor in those. And if you don't have a hip problem, it's probably not that big of a deal. But if you do have a hip joint problem, whether it's, labral pathology, FAI, dysplasia, that it causes trouble. So certainly we're very cautious about it. I wouldn't say that I've banned clamshells and sideline hip abduction from my rehab protocols, but those are exercises that tend to be performed mostly in clinic with supervision for a couple sessions before they're given for home, or just avoided for home in general to make sure they're not overcompensating it, at least in our practice.
Well, I agree with you. In my talk at ISHA, I like put up the clamshell and I like put a giant asterisk on it because it's gotten such a bad rap. But I do really think that, we know it's a good exercise in terms of muscle activation. It comes down to, do you spend the 15 minutes educating the patient on how to do it? And if you educate them on how to do it, it's probably a fine exercise to use. And it's gotten such a bad rap. And people are like, if you have a hip therapist who's doing this, they don't know what they're doing. And I totally disagree with that approach. I agree some people shouldn't do the clamshell, but I don't think no hip patient can do the clamshell. I don't necessarily subscribe to that.
Yeah, it shouldn't be completely gotten rid of. Yeah. I agree.
Yeah, but that's how some people act. They,
No,
I've
I
had
know.
someone come in and said, like, if you're a hip therapist and you use the clamshell, you clearly don't know what you're doing.
Is that like social media BS, do you think? Just because
Yeah.
someone that thinks they know what they're talking
Someone
about
somewhere said it, and it's just like
in social
it's just
media,
like
and so
spiraled
everyone
out of
goes with
control.
it, and then all of a sudden we're all idiots because we do a clam
Because
exercise.
there's a lot of
I've
ways
not
you
had
can.
that experience.
Yeah.
So Keelan, you're pro clam?
I'm pro-clam in the sense that I use it, and
Yeah,
if it's not tolerated well, or they can't do it correctly, I'm not over aggressive with it.
Yeah.
You're
Both
right.
Ashleys seem to be pro clam. That leaves Rob Roy. Are you pro or con clam, Rob Roy?
Yeah, I'm pro as long as it doesn't aggravate them. So again, as we all talked about, it's proper technique. Make sure they're not compensating. This is one you want to maybe underdose, because I think you find people try to cheat, right? So we've all seen people do terrible abduction. They bring it into flexion, they externally rotate, and because they have a weak glute med, they're compensate with their hip flexor. And I would say the same thing is for the clam. So this is one you may be dose a little bit lower than you might think, just to make sure they're not.
Should be safe.
Yeah.
Phil, are you pro clam or?
Yeah, Phil, you pro clam?
Yeah, if it's done correctly, right?
Clam bake, right?
Yeah. He's definitely pro clam bake.
No, charbroiled oysters.
Yes, that's right.
The key to the clam too is really about the thing that people don't always remember is taking the leg that's on the bottom and push the leg that's on the bottom into the ground. And that's a good way to kind of help stabilize some things too.
Yeah, I agree. I think there's like 800 different ways to modify the clam that could make it better or worse depending on the patient. I actually stole, Tim Tyler's the one I stole his, where he does, knees are stacked. He actually lifts the feet up. So he's starting an internal rotation and then opening up. So you're actually, the only thing you can do is externally rotate. If you preset yourself into the feet up and internal rotation, you open up that external rotation. Patients actually have a lot harder time cheating from that. So I'll give Tim Tyler some credit on that one. I stole that from him. I don't know if he made that up or stole it from someone else, but yeah, I think, and someone asked in the chat, do you guys do your clamshells with hip inflection or in hip neutral? And I certainly try and bias the position of the legs just where I can find that the patient can do it correctly. So
I think too, in my view, if someone has hip flexor pain in the clamshell, then I need to reevaluate kind of my exercise prescription. It's probably too hard. So do I go back to supine? I think of it very similar to how I think about like a TA progression in supine. If people are getting too much TA activation, it's probably because they're not ready to do what they're doing there. They're not strong enough, or they don't have good muscle activation. So I think that should make you think like, I need to rewind a little bit. I haven't probably laid down my good foundation here, and I need to go back and do that before I do this.
yeah.
Great points. Great points.
Yeah,
Another really
points.
important tip I thought was a great tip. You mentioned that a lot of everybody agreed that sometimes with these patients, and I think this goes to a lot of patients, starting the lumbopelvic training in supine, progressing to standing. And I think a lot of people, I mean, that's just like this hidden pearl in this to me, because I think a lot of people think, well, I've got to have them up in a functional position to work all of these muscles. Sometimes they don't have enough strength to do it in a functional position. This isn't uncommon. I don't see as many hip patients. I see a lot of knee patients, but there's a lot of people with knee pain that have hip weakness. And a lot of times they have so much knee pain, you really can't do a functional activity in weight bearing to begin with. So it's not common at all to start knee patients in supine, just like you're talking about with this study. So that's a great pearl, I think, that maybe a lot of people don't think about, or they try to rush the strengthening and do it in more functional positions or weight bearing positions, but I don't think we need to.
We're super big on like a supine, quadruped, tall kneel, standing. Like you progress through there, and then once you get into standing, they look pretty good because you've progressed them through all these kind of other phases. I don't know, Ashley.
Yeah, using those quadruped and various kneeling positions really helps take away all the compensations they've developed over the years of hip dysfunction that they use with their feet and the rest of their body. So you put them in quadruped, and all of a sudden, I mean, it's like a fish out of water. It's super challenging, but it also really helps almost reprogram their brain on how to do it the right way. So we do the same thing.
We have Jody, looks like Steiner, maybe is the pronunciation here. Please review the proper technique for the clamshell. What are some of the main tips? Phil, you said pushing the bottom leg into the table. What are some of the other tips you guys give to do it using proper technique?
Yeah, I mean, I think the biggest thing is keeping your hips stacked. I mean, I think when you roll your hips into, when you roll your trunk into external rotation, or, just try to open and you're not staying in perfect sideline position, your hip rotates. That's when I think the real problem starts. So the modification to, start an external rotation helps to prevent that. The amount of hip flexion is, just enough to be able to activate the glute. So you put your hands on their glute and make sure that they're firing that, and make sure they're firing their external rotators. But to me, it's a tight core, right? Your pelvic tilt or pelvic stabilization, even sideline, keep that hip stacked and make sure they're only activating and moving in the way you want.
Yeah,
Okay.
I'll use the top hand. So if we're on left side, right leg on top, I'll take the right hand, have them press it palm flat into the table and push down. So they're creating a little bit of core engagement through the upper extremity to create some stabilization. I mean, bottom line is if your patient's over there repping out easily 20, 30, 40 clamshells with, no sweat, no shaking, no anything, they probably aren't doing it right.
Yeah.
So,
yeah. Great
even
tips.
without resistance.
Yeah. Great tips. And Anne, thank you for your comment. I think that's a great commenter also on the chat. We have like 1 minute, guys. It's like this time flew. It's like an hour, and it just like went by, and like it seemed like 5 minutes to me. I don't know about you guys. Does anybody have any parting comments you want to make before we close? Let Ashley close us up.
I'll let the author speak. Nothing?
No closing comments?
I mean, obviously this is something all of us on this call are very passionate about, and I'm honored to be friends with and colleagues with everyone on this call, and we all learn a lot from each other. So, I think we're all very passionate about the hip world. It's a small world compared to the knee and shoulder and outpatient ortho sports med PT, but we are growing and we are welcoming. So those of you who have an interest in the hip, obviously feel free to reach out to any one of us. We're happy to share our knowledge. And I always encourage people, if you happen to be in Nashville, come visit, hang out in the clinic with me, see what we do. So I think there's plenty for us to learn. In my 9 years of doing this, I've learned a ton, and I keep learning something new every day. So just appreciate everyone on this call. And
No, I do too. Yeah, I learned a lot tonight just listening to you guys and listening to Phil talk about stats again. It's we were talking about this after one of the other journal clubs, one of the first couple. It's just like amazing how much you feel like you kind of know a lot of this stuff, but then you hear other people talking about it, and you hear other people's perspectives of a given study, or why, with little details of it that they picked out that you didn't even think of. So every one of these I learned a lot and a great deal. So thanks, Ashley, for helping us get these all set up. Phil, thanks for joining again. And Ashley D and Keelan and Rob Roy and Mike, thanks for your help, and thanks for joining us for this journal club.